not going to walk away today ready to go ahead and lead a rapid response, but just to give you some of the framework that you'll use going forward. And then as we go through the year, we'll practice some of those skills, get you more comfortable. So by the end of intern year, you feel like a lot more comfortable to step into that role as a rapid response leader when you're a resident. So just give you some background. I'm going to be running this course along with Dr. Raikhel and then Dr. David Carlbaum, who's over at the VA. He's a critical care attending. Some of you may have met him already. This pager and this sound makes you nervous. That's very normal, especially at this point in the year. Some of you may have already encountered this to some degree. So I just want to kind of get an idea from the group. I'm going to stop my screen share for a moment. Or I guess I'll just take a look through the pictures. But just as like the raise of hands, little emoji, how many people have actually been in a rapid response so far? So it seems like a fair number of people have already encountered this. So just put in the chat some thoughts. How did it feel to participate in the rapid response? Scary. Patient had frank hemoptysis. That is very scary. I agree with you on that. Stressful. I've been attending for 10 years. I still get tachycardia. Very true, Gabby. Yeah, so this is a very stressful situation. And I think one of the things that a lot of you may be feeling is you walk in the room and you have to think, what is going on with this patient? You're already stressed. Everyone in the room is stressed. It can be really chaotic. It's really hard to think through, what do we actually do for this patient? So one of our goals is to come away from today and to come away from our program thinking of a rapid response as kind of an algorithm. So you can walk into the room and just follow those steps that you've practiced, you're feeling more comfortable with. So you have something to rely on those first couple minutes while you're not sure exactly what to do for the patient. All right, so what is a rapid response for some of us that have not attended it? So it's a situation where you need additional help, whether that means you need more nursing or a higher level of nursing, you need respiratory therapy, or you're in an acute care setting, you actually really need the patient to be in a critical care setting. So it'll allow you to set up that setting right in the room. That would be called rapid response. So maybe the patient just looks sick and you're all starting to get used to that at this point. You walk in a room, patient doesn't look right, and you know that there might be something going on, you may need additional help. If there's a change in acuity, or there's a big change in vital signs, patient's decompensating, they look unstable, or they're on the acute care floor and maybe they're not even sick, but you just know that this patient needs to be in a higher level of care. So what are some things we might see? And we've noticed kind of overall, you tend to see 4 main categories of things, and those are usually mental status, hypotension, there's a hemoptysis, or whoever mentioned that, respiratory distress, and arrhythmias. And these are kind of common themes you'll see. There can be other things outside these, but these are common things you tend to see. And where can this happen? It's probably the most common place you'll see this. You're on the acute care wards, you have a rapid response, you've got your resident, maybe you're attending there. But this can also happen on your
totally forgot we had this thing.
And then, probably the thing that makes everyone a little bit more scared is, what do you do when you're on night float and you're the resident, the intern that's alone? It's going to happen a lot on night float. Our patients love to decompensate at night. And then you can see this at any of our sites at Montlake, Harborview, the VA, and it might not actually be called a rapid response, but you could use these same skills. A patient gets sick in clinic and you kind of have to set up either that acute care or ICU room right in the spot in clinic. So we've said this is pretty intimidating, right? It's a scary situation. A lot of things can happen. It's an acute change. It can happen anywhere. So it sounds pretty scary, but just keep in mind, as an intern, you are absolutely never alone. If you're on wards, you have your resident with you there. If you're that night float intern, you feel like you're totally alone, you're not. I promise you, there's always an attending in-house and they're available for you in these situations. Even aside from all your physician colleagues, your nurses are there and they are used to dealing with this, and you have that backup. And we'll talk about it a little bit more, but there's a very specific nurse that's always going to be available to you, and that's a stat nurse. And this is a nurse that does rapid responses pretty much the entire day, and they have a really good understanding of how to deal with these situations. So just keep in mind, it seems scary, but you're not alone, and you're not expected to walk out of here being able to manage a rapid response by yourself. But our goal for today is that you feel more comfortable facilitating. It's your job as a leader, even just as the intern in those first couple minutes of the rapid response, it's not to know everything and know what to do, but it's knowing how to facilitate the teamwork. So that's through working with your team, communicating with your team, and then figuring out what resources do you need, whether that's the nurse, your resident, your attending, or other resources in the hospital that might help you manage the situation. So our goals for today is, what do you do in those first few minutes? Because it is very possible that you walk into the room, you realize patient needs a rapid response called, or they already have one called, and someone's not there yet. So how do you take an algorithmic approach to those first couple minutes so you can feel more comfortable and develop a plan to stabilize the patient while you're getting more help? So to do that, we'll review some of the steps to facilitate a rapid response. And then we'll also take a look at some of the resources that are available to you to help you in a rapid response situation. And then we'll just quickly touch on some best practices around rapid response. I just want to say overall, again, stating today, I don't want you to feel that you have to walk out of here memorizing everything we said and feeling really confident. The goal of this program is, this is our introduction, and then we're going to spend the year working with you as you gain more comfort, as you gain more knowledge throughout the year, so that really by the end of the year, you're starting to feel more confident. You feel like you can step into that role. So I'm going to start out by sharing a video. And this is a quick clip of the start of a rapid response, just those first couple minutes. And as we watch the video, I want you to really pay attention to what are some of the team dynamics? What are some of the ways that the team's reacting? And then after we watch this clip, I'm going to turn it over to the group to see what are some of the reactions you have to how the group is interacting together and how the team is managing this patient.
Hi, my name is Vince. I'm the senior resident. I'll be leading this rapid response. This is Kyle, my colleague, the intern who will be working with me.
Alex, I don't think we can see the video right now.
Oh, okay. Thank you. Let me screen share. All right, can you see it now? Okay, perfect, thanks.
Vince, I'm the senior resident. I'll be leading this rapid response. This is Kyle, my colleague, the intern who will be working with me. Can you remind me of your names? I'm David. I'm the bedside nurse.
I'm Alex. I'm the stat nurse.
Thanks, Alex and David. David, do you mind telling me what's going on here?
Yeah, this is Mr. N. I came in to do vital check and had all this blood all over him, and he says he feels sick. And so I called a rapid, and then Alex came.
All right, sounds good. Can we go ahead and get a full set of vitals?
Full set of vitals. Actually, there's a full set.
Mr. N, can you tell me what's going on, what you're experiencing?
Lightheaded. I was just watching TV and then I Robert in blood.
Okay.
Sorry, sir.
I'm very concerned that this patient is having an upper GI bleed given this presentation. I'm also looking at him and seeing only one point of vascular access. Alex, would you mind establishing 2 large bore IVs for us?
Yeah, sure. I'll put in a second IV.
Thanks. Kyle, would you mind looking up this patient in the electronic medical record, get a past medical history, most recent H&H, coex, and code status, please?
I'll pull up the chart right now.
All right.
Dr. R, the blood pressure is 89 on 40 and the heart rate's 126. And satting 94. Is it okay if I put him on some oxygen?
Yes, please.
All right, so we'll pause there. Let me reshare. All right, so I'd love to get either have you unmute or put in the chat, what are some reactions that you have right off the bat of how's this team interacting? How are they managing this patient? What are some of the words you'd use to describe their interactions? Staying calm with good closed loop communication. Yeah. Closed loop communication. Clear roles identified. Closed loop communication. Delegation. Prioritizing vitals. Yeah, you all bring up really good points. I think we pointed out, sorry, my cat's trying to join, join our conversation. Pointed out good closed loop communication, very important, delegating roles, prioritizing vitals. And I think those things came across pretty clearly in the video. So that's a really good intro. And now I'm going to hand over to Dr. Raikhel, who's going to walk us through what is that algorithmic approach that we would suggest in a rapid response in those first couple minutes. And I think you'll see that some of the things you're recognizing are exactly how we would recommend managing these situations. All right, so Dr. Raikhel, I'll hand over to you.
Great, thanks. So I think one of the most stressful things about a rapid response is that there's just so many things that could be going on with the patient and so many reasons that a rapid response could be called. And so kind of having this more stepwise algorithmic approach can be really helpful to almost kind of mimic the way we approach a code, which, you know, a code blue can be like really stressful, but it's also like very algorithmic. And so we know like kind of just what needs to happen in terms of steps. And if you kind of like organize your first few minutes of a rapid response in a similar way, where you have like a set of things that you want to establish, it can really give you a moment to collect yourself, get the information you need in order to help the patient. Alex, could you mind going to the next slide?
Alex, I don't think it's advancing on our screen. Sorry, we can't hear you.
Oh, sorry. Are you seeing anything? It's not moving.
We're seeing the like a image of our video.
Oh, sorry, everyone. Can you see it now?
Same,
Nope.
same.
Same thing. Now, same thing. All right, let me just stop share and reshare. Sorry about that.
No worries.
All right, can you see it now?
Yes, perfect. Yep. All right. So do you mind going back one slide? So really the three things you want to be thinking about are the first thing is going to be your primary survey. And there's a few things in there, but that's really a moment where you're kind of getting your global gestalt of what's going on, get your most important information. And then using that, you're going to kind of think about, you know, what are some of the most immediate things that I'm concerned about? Remember, we're not, you know, you shouldn't think about the goal of this or really put the pressure on yourself that you're going to be running a rapid response from head to tail right now. But like Dr. Collis was saying, it is very reasonable that, you know, you get called to a rapid response, you're the first one there for the first 5-10 minutes. And you want to make those a powerful 10 minutes to advance the care of the patient. So identifying like, what are the immediate concerns? How can I move care forward for this patient? And then you want to get resources and use your help. And so those are kind of like the three things we want you to think about. Can we go to the next slide? Awesome. So a primary survey, as you guys pointed out, you know, vitals, get those early. Can't stress that enough. Even if your page with, we're calling a rapid response, the patient is hypotensive to 80/40. Okay, great. Get another set of vitals as soon as you come in. Get a full set of vitals. It's going to really help you understand the full picture of what's going on. So a patient who is hypotensive to 80/40 with a heart rate of 20 is a very different situation than one with a heart rate of 120. And so you want to really get that full picture because it's going to really start to help you triage. Who do I need to call? What other things do we need at bedside? What type of emergency am I concerned about? So can't stress that enough. And it also just gives you a moment to kind of take the room in. When you're getting that vitals, when the blood pressure cuff is going, take a breath. Then you're going to assess your ABCs. And this is like the very basics of an emergent physical exam. So this is a specific skill I think everyone should think about working on is your 30-second physical exam on a patient who is decompensating, focusing on your ABCs, airway, breathing, and circulation. And, you know, I would be conscious of try to really develop this and think about how quickly you can get the information you need. And, you know, the one of the most powerful things I like to pay very close attention to is the mental status of the patient. You're going to go and be like, in that case, Mr. N, what are you experiencing? If they're talking to you, you're in a pretty good place, right? If they're talking to you, they got a mental status to hear what you're saying. They can talk to you. They have an airway. They're circulating because their brain is getting enough blood that they can talk to you. You've got a lot going on. If they're, you know, not able to respond to you, then and your mental status is someone who's obtunded or confused, then I think your triaging of how worried you are should increase. And so you really want to be then focusing on, okay, what is this patient's airway? Are they really protecting it? Are they breathing? And then the circulation. And really early on, you also want to get the information about the patient's code status. You want to be kind of ahead of the ball on things. And if this is a patient who's, you know, do not resuscitate versus full code, you want to be able to activate the necessary resources early on. And totally reasonable, like we said, like this is potentially a night float situation, not reasonable to think that you would know all of these patients off the top of the, you know, just walking into the room. So, you know, get that information. The bedside nurse should know these things for the patient, and you can pull up the chart. So, yeah,
Vince,
please.
can I, sorry, jump in for just 1 second? Just because I think early on for interns, especially folks who might be new to our system, it's helpful just to know about that purple dot up for code status that I know happens at UWMC, Alex, with the DNR DNI status. And I don't know if there's other specific designations at the VA, for example, but that can be helpful just as terms of your primary survey of code status around the room.
Yeah, thank you. There are like these visual markers that are meant to be, yeah, just visual cues that indicate a do not resuscitate. So at the VA, we have purple bracelets on patients whose code status is DNR. And I'm assuming the purple dot indicates that at Montlake. Is that correct, Gabby?
Yeah, and Alex, I know you're a hospitalist here as well, but there's for interns to know there's like a square laminated sign that has a purple dot. It's literally about this big, and it's just a big round purple circle, and it says DNR, DNI underneath it, and it is usually taped to the wall above the head of the bed for patients for whom they are DNR, DNI. There also is oftentimes a designation outside the door with a purple dot next to their name, but that is smaller, but that's another visual cue you can use as you're entering a room for a rapid response, especially if you're sort of cross cover and this is a patient you don't know, but you can look for that purple dot inside the room. Yeah,
thank you for that reminder. These visual cues are super important, super useful, and you're probably already like understanding, like you're in a system with, you're in a training program with 3 hospitals, and each one is going to have their own nuances, but it's really valuable to kind of like understand each system a little bit. But these purple visual cues indicating that a patient is do not resuscitate should really be at your front of mind, because that kind of puts like a line in the sand about how far that patient's goals are in regards to resuscitation. So going into your physical exam, we're going to look at these 3 elements and kind of just give you a sense of like, you know, what are some first steps you should be thinking about that you could do while you're getting more support. So the first thing, you know, is the airway. You know, we're internal medicine doctors. We like to think, we like to discuss things, and like, you know, are we going to change this dose? You know, so there are a lot of things we have a lot of time to talk about. And I would say like an unstable airway is one of the very few things that we really don't. And so it really, if that's something to be very concerned about early on, if you are worried about a patient who either is not protecting their airway or just doesn't have a stable airway. And so that would be a reason to call, if you're ever concerned about any patient's airway or breathing, I would definitely make sure that you have respiratory therapy at bedside and you're getting their thoughts right then and there. But I want everyone here to feel empowered and have a low threshold. If you are concerned about a patient's airway, you need to call anesthesia. You need to potentially call a code intubation. That is something that everybody here can call. It might feel scary to do, but if you're concerned about somebody's airway, like I said, that's not something we really have some time to hem and haw about. We really need to get that patient the care and help that they need, and that is the one team that can intubate that patient to get a secure airway. And it's a lot easier, if the team gets there early and can kind of do it in a more controlled fashion. It's a lot better than if we delay and it's a little bit more, it's a more rushed job. And also, everybody would be okay if they don't have to end up doing it. If they are like, oh, actually, I think we're okay. Thank you for coming. Looks like the patient's airway is actually stable. That's okay. That's not like a fail. That means that you still did the best thing for that patient. And so I want to empower everyone, make sure if you're worried about a patient's airway, get that team coming early on. But other things that you can do when you step into the room, if you're concerned and you're like, this patient's not breathing, I don't think they're protecting their airway. If you're at the front of your first one in the room and you're just like, I'm gonna jaw thrust this patient and we get more help. That's awesome. That's great. You're doing the best thing for that patient. If you can get suction to make sure there's nothing obstructing the airway. These are also things that you can ask RT to be doing and working on. These are the things that you can do to help address the airway right off the bat. Next thing would be their breathing. So as part of your vitals, you're going to be getting that patient's oxygenation. And I just, again, you all are going to be there in the room, and I want to empower you to do some things for that patient. If you just throw on a nasal cannula and you just pump it to 12 liters, that may not be the most elegant way to oxygenate that patient, but that will get that patient more oxygen than they were getting before. And respiratory therapy may come in and change the device that the oxygen delivery device that the patient is using, and that's fine. But I want to empower you to use whatever things you have right there to just fill in that gap. Remember, it's not your job to be to know everything. You're just kind of facilitating things for that patient. And if that is just kind of as a stopgap to get a little bit more oxygen on that patient right then and there, that is totally fine. I also, in terms of identifying reversible causes, that's going to be, obviously the key to these things. A patient decompensated and you're trying to reverse that, trying to stabilize this patient. And so when you're thinking about identifying your reversible causes, I really want everyone to focus on getting diagnostics that'll be really useful in the moment. And so can anyone throw in the chat, what diagnostic tests would you think would be beneficial in a rapid response that you can use right then and there? Yeah, I love it. Point of care glucose, a VBG or an ABG, lactate, ECG. You guys are all honing in on the right kind of tests. The other one I would throw up there would be a chest X-ray. They're going to shoot it, and you're going to be able to see it right there. So what you're honing in are tests that will result very quickly or at bedside, and you don't need to move the patient, right? And so these are the kind of tests that you want to be focusing in on. You guys are, if you go into a rapid response and you order, you don't know what's going on, and you order an ECG, a chest X-ray, an ABG, and a glucose, your goal, I mean, that's great. You're going to get so much information from that, and you're going to be able to, in terms of what the most common causes of a rapid response are, you're going to be able to prioritize and get a lot of information. And so if you have those in your back pocket of oh, I'm walking through the room, I don't know what to do, keep those 4 in your back back pocket of like the things you're just going to order, and then you're going to get a trove of information. Okay, next slide. And then the next thing is like circulation. You know, quick and easy way to kind of assess that. You're going to listen to the patient's chest, but also just like, you know, touch their hands and their arms as you're kind of walking in the room, and just kind of get a sense of how is this patient circulating. Early on in a rapid response, it's really worth assessing that patient's vascular access. If you're like looking in the room and they have 128 gauge in their pinky, you know, that's something you probably want to address early on. And it's also really easy for us to just say like, we need more vascular access. I want everyone to be mindful that that is a job that takes time and energy from probably one of your more experienced people in the room. And so it's a very important job, but you are going to have to like acknowledge that it takes, in the best cases, 5 minutes, but like maybe even more, 10 minutes of your experienced nurse's time to establish that. And so I feel, you know, it's really easy for us to come in the room and just be like, we need more vascular access, we need an ECG, we need a chest X-ray, we need all these things. And I just want everyone to be mindful that all of these tasks take time. The establishment of an IV is a very important one, one that should be prioritized, but one that you need to acknowledge is a like standalone task that's going to take all of the time and energy of that experienced nurse. In terms of like, you know, if a patient is, you know, in circulatory collapse, they're hypotensive, you know, you might think like, okay, we want to get a bolus or something going on, or blood, like in that video, if you see the patient is vomiting blood, you may want to jump to that. And you may end up in a situation where you're like, I'm really worried about this patient, you know, I think we need some pressors. And those situations can be scary. And I just wanted to, like, as a general framework, let everybody know. So as a general rule, we kind of think like, okay, pressors equals ICU. And that is true. But I just want everyone to know that if, like, when you call a rapid response, that patient has essentially been absorbed into an ICU. Like, they have an ICU that has surrounded them. And anything that you can do in an ICU, you can do for that patient on a rapid response. So just because the patient may physically be on an acute care service, if that patient requires pressors, you can start them there. That patient is not going to stay on the acute care service, but don't think that you need to physically have the patient moved and be in an ICU before you start these things. If you are in a situation where you think that's clinically necessary. Now, at that point, you know, if you're at the point where you're like, I think this patient needs pressors and I'm going to order them, you also should be talking with that ICU team where you think that patient is going, because, you know, obviously that patient is not going to be able to stay on the acute care service, and we want to keep that patient safe, which is our, you know, main priority throughout all this. And so getting these ICU teams involved in early, I think, is another really important aspect. As soon as you think like, you know, this patient is just not going to, we're not going to be able to reverse this, or this patient's going to need really close monitoring afterwards, just get them involved as a kind of, even as an FYI, another like perspective on what's going on can be very useful.
Hey, Vince, can I ask a question that I would imagine is on some people's minds, maybe, recognizing that it's second month of intern year and maybe hard to ask some of these questions. If you're thinking that the patient is so hypotensive that you need pressors, should we call a code? How you say get in touch with the ICU team quickly? What is that? How does that? What does that actually look like?
That's a great question. So, and we have a slide in a minute where we'll kind of break down like what, you know, how are you kind of doing these various, like when do you call a code versus a rapid response? If you're like, I think this patient needs pressors, I think if you're at Harborview or Montlake, the easiest thing to do is you stay in the room. You don't need to call a code blue unless the patient has lost a pulse. But I would page the ICU to kind of get them and talk to them about what's going on. And so if that, this is a really important task when you start to have a team of people, is one person can be leading the rapid response, and then they can delegate, Gabby, we need some help. Can you go ahead and call the ICU, let them know about this patient, we're starting pressors. And they will then shortly come to bedside. As Gabby just threw in the chat, the stat nurse is going to be a super helpful person to be able to help facilitate that transition if needed. And I'll talk about the stat nurse more in a minute. At the VA, we kind of make it easy because the ICU responds to all rapid responses. So they're kind of they're going to come. You're going to get them, as a bonus. So that's a nice thing about the VA. So this is, in terms of, at the end, you want to really, or throughout all of this, you want to focus on your communication and how you're working with your team. How are you facilitating this? Like we said at the beginning, it's not your job to know everything, but you do want to facilitate the care of that patient. And a lot of that just has to do with how you're communicating, how you're working as a team. And so make sure, you identify yourself. All these rapid responses are called action teams. It's not like you have practiced with these people before. You're likely meeting these people for the first time, and you need to be able to do stuff together. So identify yourself, stand at the foot of the bed. You're standing at the foot of the bed for multiple reasons. One, everybody knows that the team leader stands at the foot of the bed. So you're identifying I am the team leader by standing there. And also it gives you the best overview of everything. You have a great view of the patient. You have a view of the vitals. You can see what's going on with all the care. And so make sure that you're standing at the foot of the bed. Ask who the other people are. You're going to be working with these people to help, save this patient. You want to make sure that you have some rapport, and it's just really nice to ask what people's names are before you're like, we need this, we need that. It doesn't take that long, and it is definitely worth that tiny investment. And you want to be identifying clear roles. Can we get 2 large bore IVs? See if you hear the closed loop communication. Make sure that we have specific discrete roles for everybody. Get the story, events leading up to the rapid response, notable past medical history, medications, and I can't stress this enough, early on in a rapid response, get the help you need to care for that patient. Call for anesthesia, call the MICU, get the RT, talk to your stat nurse, get the help there early. And it's easier for people to be able to be like, oh, it looks like you got everything under control by the time we got here. People love going back to their office after you fixed everything. It's much more worrisome for that patient if we waited a little bit longer and then we're in a more of a stressful situation. And as Gabby was mentioning, so the stat nurse is, just a huge resource, your number one resource in these situations. So when I was an intern, I didn't have a quite clear understanding of what a stat nurse is. So a stat nurse is an ICU level nurse. They have ICU training, but they float throughout the acute care service. And so they will be called to every rapid response in the hospital. And they also are rounding on the peri ICU patients, the more worrisome patients on the acute care service. They're kind of floating around and getting an extra set of eyes. If you're ever worried about a patient, you will endear yourself to that. You will do the best thing for your patient and endear yourself to that bedside nurse by saying, let's get the stat nurse's thoughts on what we should do here. Anything that can be done by an ICU level nurse can be done by the stat nurse. So if that's starting pressors, if that's putting in other types of IVs, if that's putting the pads on the patient, the stat nurse is going to be your resource. And they, as Alex was saying, they respond to every single rapid response in the hospital. And so they have a lot of experience with this. And so, they are your resource to help, if you're worried, during every rapid response, I try to turn to the stat nurse and be like, what am I missing? What else should we do? What ideas do you have? Because this really is their specialty. There are a lot of different types of emergency response teams, and throughout your training, you will potentially call all of these. And all of them kind of come with their own algorithm and their own team. And what I want you to notice is that the stat nurse comes to all of them, right? And so the stat nurse is just like a super experienced person. And so if you call the rapid response, you're going to get your stat nurse, you're going to get your respiratory therapy. And then, if they're like, oh, actually, I think this is a, more of a code stroke or code STEMI, they can help you get there. Don't stress and think like, oh man, I got to memorize all of these algorithms. That will come with time, and you will have experience calling all these. And I just really want to hone in. The stat nurse is your go-to emergency response person in the hospital. So in this situation, I want to break it down and be really simple. Like, who should you call? So if the patient is breathing and has a pulse, but you're worried, call a rapid response. That'll get the help you need. If the patient is not breathing, but they have a pulse, that's a code intubation. And so you want to get that patient with anesthesia as soon as possible. And if there's no pulse, you're calling a code blue.
Hey, Vince. Sorry, I'm going to jump in again just because I've got a couple of folks messaging me in the chat, in the private chat. Can you tell our interns, what is the mechanics of actually, how do you call a code?
Oh, thank you. That's awesome. So most, all the rooms have a code blue button at the head of the bed. That is one way to do it. The other way to do it is I guess there's three ways. You can push that button. You can ask the nurse to call a rapid response, call a code intubation, call a code blue, or you can get on the phone and call that to the operator. If you're at Harborview or Montlake, secret code 222, get you to the front of the line in front of every other person on the operator, and then you can call that code. So
cool. And I just want to, awesome. 222. And I also just want to say, usually as the intern or the person, if you are like the intern and you're responding to that rapid response first, and you are worried, you should not take time to step away to call. You should delegate that because there will be a nurse in the room. There's going to be a stat nurse who shows up. You say to somebody, call a code blue, you delegate that, or you say, call a code intubation. That should not be you taking your time to get on the phone to call.
Absolutely. I couldn't agree more. And, it's always better to err on the side of caution. So if you're like, I don't know, did I feel a pulse? I don't know. Call the code blue. I know it sounds scary, just call it. And if it turns out the patient is more stable than you thought, that is great news. And everybody is fine with that. But I'd say front load the help that you're calling, and then you can back off.
Vince, real quick, hopefully you can see this. I just wanted to share. Can people see? This is what the code blue button looks like. People can see that. So it's right on the wall behind the patient. Press it, it activates on the unit, and then the unit will call the code. So yeah, it's just kind of delegating that role to someone else.
Awesome. So, and then just wrapping up, just making sure you're in terms of communicating, identify yourself and your team members, use closed loop communication. If you're not hearing things, kind of come back, follow up, and kind of encourage your team to be using closed loop communication, making sure you're taking times to summarize what's going on. This is about having a shared mental model so that you're all on the same page, and then really be open to getting input from your team. And I think that, the way I do that is I always just be like, does anyone have any ideas? Be really active in kind of asking for that feedback so that other members of your team, nursing team, RT, feel free and empowered to share their ideas. Putting it all together, identify yourself, make sure you get your vitals. Vitals are vital. Stand at the foot of the bed, You want to be clear about assigning roles and assess the immediate stability, address the immediate stability. We talked about, you guys have on top of your head the diagnostic tools that will be so powerful for you. Get the story and then get those resources to bedside. Go big early on, and then you can back off.
All right, thanks, Vince. So we're going to watch that video one more time, and actually, let me go back. I really want you to, putting this all together. This is the algorithm we're hoping you'll walk away from today. But again, this is not for you to memorize today. This is something for you to practice over the course of our sessions. But we're going to watch that video one more time, and I'm actually going to pause it for a second and just kind of call out these things so we can see it in action, see how it looks. And I think you may notice that's what we picked up on the first time we watched it. So let me share the video again.
Hi, my name is Vince. I'm the senior resident. I'll be leading this rapid response.
All right, so we noticed he identified himself, stood at the foot of the bed.
This is Kyle, my colleague, the intern who will be working with me. Can you remind me of your names?
I'm David. I'm the bedside nurse.
I'm Alex, I'm the stat nurse.
Thanks, Alex and David. David,
All right, so he identified the other members of the team, assigned roles.
do you mind telling me what's going on here?
Yeah, this is Mr. N. I came in to just do vital check and had all this blood all over him, and he says he feels sick.
Got a real fast past medical history, past event history from the bedside nurse.
And so I called a rapid, and then Alex.
All right, sounds good. Can we go ahead and get a full set of vitals?
Getting our vitals.
Full set of vitals. Alex, there's a full set.
Mr. N, can you tell me what's going on, what you're experiencing?
Yeah, I'm feeling really weak and lightheaded. I was just watching TV and then I vomited blood.
Vince is doing that real quick assessment of immediate stability. Is the patient talking? Are they awake? What's our assessment?
Okay,
Sorry, sir.
I'm very concerned that this patient is having an upper GI bleed given this presentation. I'm also looking at him and seeing only one point of vascular access. Alex, would you mind establishing 2 large bore IVs for us?
Yeah, sure.
Addressing circulation.
I'll put in a second.
Thanks. Kyle, would you mind looking up this patient in the electronic medical record, get a past medical history, most recent H&H, coags, and code status, please?
I'll pull up the chart right now.
All right.
Dr. R, the blood pressure is 89/40 and the heart rate's 126. And satting 94. Is it okay if I put him on some oxygen?
Yes, please.
All right. So I'd love to hear again from the group, either unmute or put in the chat. What are some reactions now that we have this framework, we've watched it in action? What are some reactions you have about the rapid response? Or just how you feel watching it or how you might feel participating? Any questions about what we saw? Putting that all together again in that second clip. How do you call for a massive transfusion protocol? That's a really good question. That's something we'll actually focus on as we go through the year too. But the way to do that, Vince, help me out if I'm missing something, but generally you're gonna actually just order it in the system and then you're gonna call down to the blood bank and confirm. The stat nurse can help you facilitate that as well. Anything I missed with that, Vince?
No, I would just like any type of order that's so important like that, I would always follow up with a call. Make sure you're actually speaking with somebody. But yeah.
That's a good question.
One thing I noticed, sorry, I've got my mask on. I hope everyone can hear me. One thing I noticed, and that has come up also as I've been on the wards and talking with interns, is just noticing in this situation, in this video, how many people are in the room and what it feels like. And then comparing that for folks who have been to a code before and how many people are in the room and what that feels like. and recognizing that these are actually really, really, really different environments in the room. And that can be both, I think, calming in the sense that in a rapid response, there are usually a few people in the room. And it's the tension can be high and you may feel your own sort of stress, but it tends to be fairly quiet and controlled in there. And it's an easier space to sort of think and take charge. Compare that to a code blue, which you are obviously as an intern not leading, but may participate in. Those rooms are crazy. And we work really hard with our code blue training to help make those rooms less crazy. But there are oftentimes 20, sometimes 30 people that are trying to like get into that room. We're having to get people out of that room. It's hard to be heard. It's hard to establish leadership. And so there's a lot of training around that. And so I just really want to differentiate what this feels like for folks, because I think what you're seeing here in the video, super calm, super organized. Obviously, they're doing a great job of all of this. And it also, like in reality, this is what it looks like compared to a code blue.
That's a really good point, Gabby. And it may feel it may make you very anxious to think, oh, there's only so many people in the room. But it's a really good opportunity to get people's names, connect with them by looking directly at them, using that closed loop communication. And then if things do get worse, you have those people you know that you've communicated with. And yeah, just to point out what Austin said in the chat, repeating but that closed loop communication saying, I'd like you to put in a second bore IV, and then the second person saying, I'm placing that second bore IV now, a large bore IV now. And someone else said, biggest takeaway, patient being terribly afraid. That's a really great point. That actually, we should have this in here as the putting it all together. Always, if the patient's awake, let them know what's going on, because they're going to be terrified. They're going to hear you using a lot of medical jargon and making sure that they know what's happening, what the next step are, and just taking us. When you have those moments of silence, and you will have them, you can fill them with summary for the group and then fill them with summary for the patient. Make sure that your patient knows what's happening. It's a really great point. Great. All right, so then we just have a couple minutes left, but I just want to talk about some of the resources that you have. Again, we want you to feel comfortable facilitating this, especially by the end of the year, but we want you to know that luckily in internal medicine, there's not a lot of things you have to know immediately. We do have a lot of time to look things up, but there's a couple things you might need at the bedside. Like you might need to know what the treatment dose is for anaphylaxis. You might need to know what the treatment dose is for adenosine for SVT. So we've created a couple resources for you so you have them in your pocket. I'm curious to see, it's a show of hands, does anyone use OCCAM? Go ahead and use the little hand emoji. Are you familiar with this OCCAM app? I'm actually not seeing a ton of, a couple people have, but not a ton of hands. So good. This is a good opportunity to introduce this. This is an app that we have through the university. It's really useful. It has a bunch of toolkits. The one that some of you may have more frequently seen is the antibiotic reference toolkit. It has like, you click on diabetic foot infection, it tells you what's the algorithm we use at our hospital to approach that. It has an antibiogram in there. But one toolkit that we've created for you to help you in these situations is the rapid response toolkit. So the goal of this toolkit is to give you immediate cues for emergency situations you may encounter, leaving kind of the more nuanced things to up to date and talking to your attending. But this is to give you those first couple things that you can do in a situation. So when you open the toolkit, you'll see all the way on the left here, you have altered mental status, shock, respiratory distress, arrhythmia, those 4 buckets that we talked about, as well as cardiac arrest and emergency response teams. And let's say you have a patient with shock, you click on that. In each of these categories, it'll give you a generalized approach to undifferentiated that category. For example, here we have undifferentiated shock. It kind of tells you what are the first things you need to do. So that's the airway, give fluids, get access, et cetera. And then if you know what the actual thing is, like let's say it's altered mental status, you know it's a stroke, you can click on that. And it'll give you this step-by-step. It'll tell you what history you should take, what physicals, labs, what are some of the next steps. And I think the thing that can be really helpful too, as you get more comfortable with manage these situations, is it has the drugs and doses for each of these emergencies. So for example, here we have seizure. first line, the raised hand, that's the dose. So you can have those things you need in the immediate moment in your pocket and pull that up. So I encourage you to kind of download the app, familiarize yourself with it because it can be really useful. And then it's just a learning tool too. Use it once, use it twice. Hopefully the next time you'll feel more comfortable with how do you approach the emergency and what are some of the drugs and doses you need. And then another part I really like you to be familiar with is the emergency response teams part of this. So when you pull that up, it'll give you just kind of this emergency response teams is just an overview of what the teams are, but the emergency response numbers is going to be your highest yield thing. When you click on that, it gives you the 3, Montlake, Harborview, Northwest. Unfortunately, we don't have the VA in here because it's through a different system, but it has the numbers for each of the things you might call, and you can actually dial through the app. So if you click on that blue highlighted underlined number, it'll actually call directly through your phone. So hopefully that will be useful for you. Then the other thing that you may use as you go along under cardiac arrest, we have the ACLS algorithms, the code cards. So that can be useful too. And then for those of you that have not used this before, you'll have these slides, and I just want to walk you through how to download it because it's not super intuitive. But let's say you were in the antibiotic toolkit. You click on this little drop-down menu here. That will pull up these toolkits up here are the ones that you already have. So you want to click on this little download button, and then that will pull up all the toolkits. There's tons of them. Take some time, go through, see what we have. The ED reference kits are pretty helpful too. But if you see here, here's the rapid response toolkit. Normally, if you didn't have it, there'd be that little download button. Just press on that and that'll allow you to access that app. If you have any questions about how to do this, the slides will be out for you. But if you're struggling to get this, and that does happen, feel free to reach out to me directly by email and I can help you make sure you get it. Some of your upper residents should have this app already. And then one last thing I wanted to touch on is just kind of best practices around rapid responses. Actually, before we even talk about documentation, I wanted to just quickly touch on debriefs. So anytime you're dealing with a situation like this, it really will serve you, it'll serve your colleagues, it'll serve the patient to take a moment and debrief. It'll help you process what you just went through, and it'll help you and your team learn, what did we do well? What didn't we do well? What can we change for next time? Sometimes just figuring out what actually happened to this patient. Do we have a shared understanding of why they got sick, what we did right, what we could do in the future? So I think debriefs are extremely important, specifically for rapid responses, also for codes. And as we go through our program this year, we will practice that too when we do our simulated rapid responses to kind of give you a framework for how do you process what actually happened to the patient, how the teamwork went, and what the medical care that we provide to them is. And then I want to touch on rapid response documentation. So I'm sure you're all already very sick of writing notes. It takes a lot of time. So why am I asking you to do one more thing and write a dedicated note for a rapid response? Well, it's actually really important because it allows us to communicate with other members of the team. Our nurses will see this if we write it in within 6 hours of going to rapid response, we write this, our nurses see what the plan is, our consultants can see what the plan is. It allows us to explain our thinking so it's there in writing and other people can refer to it. And then a lot of times, these things happen overnight, you get verbal sign off and then turn overnight. And then 2 days later, when you're off, the attending switches and you have someone covering, they may have no idea what actually happened to the patient. So having your thinking and writing, having that documented in a place that's dedicated in the notes and not just kind of hidden within your note for the day can be really, really beneficial to the patient, to ongoing care. And then I hate that we even have to talk about this, but medical legal, it's really important that we explain what we're doing in these situations that can be really, really high stakes. And just quickly, if you type in significant event into a note template at Harborview and Montlake, it'll pull up this note. And the probably most high yield part is if you type in .rrap, pulls in a smart list and you can actually select what's wrong with the patient. So you say chest pain, it'll pull in these little assessment plans down there. It'll actually pull that in. So you have a prefab assessment plan that can help you guide your plan, can help you figure out what the next steps for the patient are. And then Gabby, I know we're kind of running out of time. We want to just quickly review our steps. Do we have a couple more minutes to do that, or?
Yeah, I would say we have like 1 or 2 minutes.
Okay, so let's quickly run through this. So just quick intro. So we're going to be doing a rapid response simulation for you all throughout the year. We talked about some of the non-technical skills today, leadership, communication, and we're going to really focus on those specific technical skills as well as those non-technical skills throughout the year. So these are going to be 4 sessions throughout the year, broken down by topic: altered mental status, hypotension, respiratory distress, and arrhythmia. And they're going to run at each site. And you will just, if you're at the Harborview, when we run the site, the session at Harborview, you go to the one at Harborview. So go whichever site you're at. These are really meant to be low stress. They're a great opportunity to practice with a group. We'll start with a simulation. 4 to 5 of you are involved. One's the leader, but you're really working as a team. We debrief, we do a chalk talk on the topic of the day, and then we do a second simulation to kind of practice again what we've learned. And then along with this, you'll have 4 video modules that are related to each topic, so we encourage you to watch them at home. And you'll get an email from the chiefs coming up to this. We'll tell you about the day, the time, so make sure we get you there. So keep a lookout for that email. It's just a couple of pictures that we had from last year, our chalk talks. It's really well received. It's a great opportunity to just practice in a low stress environment, safe environment, and make those mistakes there so you can feel more comfortable in a real circumstance. And then just one more plug. This year, we're going to be doing a simulation study to take a look at how people are doing using the OCCAM app, and then also how our residents are doing that have been in this program versus not. And we'll be providing $50 Amazon gift cards if you participate. So keep your eyes peeled. We'll be sending out emails as the year goes along, and you'll just do a quick simulation. And it's a good opportunity to practice. It's a good opportunity for us to see if we're being effective in our teaching. So that is everything. And see any questions that anyone has.
As we're wrapping up, and we'll keep monitoring the chat for questions, just want to thank Vince and Alex, Drs. Raikhel and Collis for joining us this morning. I think this is an incredibly helpful orientation and sort of primer on rapid responses, particularly at our hospitals and your role as an intern. I've put the evaluation link in the chat, so please do take 2 minutes to fill out your evaluation so we can always make our sessions better for your colleagues next year. And we have 2 more ITC sessions left after today, but feel free to stay on and ask questions if you have them. Thanks, everyone.